Thank you for that great talk, Dr. Po. We're going to talk about endovascular options now. Okay, so in terms of management of aortic disease, as I mentioned earlier, we have surveillance sometimes for patients who have known disease but still under control. We continue to have regular surveillance. Medical management means we control blood pressure and all the lifestyle factors and so on. And then we mentioned already about open surgery. So I'm going to touch on endovascular treatment and what we are doing nowadays with stents. Terminology. When we talk about endovascular, what we mean is we are treating the disease from within the blood vessels. So that means endovascular. And the stent grafts that we use, an example of the stent grafts that we use is on the right. It's basically made of a cloth-like material with metal reinforcement. And these stent grafts have been developed for a long time. They're able nowadays to be crimped and put into a smaller profile so that they can be inserted normally from the femoral vein, the arteries in your leg, and into the aorta. And that's when we can deploy and put them to sort of cure the aneurysms. Now, I will mention that a bit later. Other terminology you need to know, when we say thoracic, we mean above the diaphragm. When we say abdominal, we mean below the diaphragm. Now, aortic repair is the process of excluding an aneurysm. So these stent grafts started being developed in the mid-1990s. Initially, they were very big, very bulky, and it was difficult to deliver them into smaller arteries. Over time, and with technology, companies have been able to make it smaller and easier to deploy. And so now, as most people probably know, there are some options for certain patients who either cannot be treated with surgery or they are suitable for endovascular treatment, that we can offer these solutions to patients in a less invasive manner with these improvements in design. In terms of evaluation and screening, when do we offer endovascular treatment? When patients are referred to us, we go through all the clinical details and take a history. We normally have to evaluate, as Dr. Silvraj mentioned, with a CT aortogram, and we look at the various treatment options. So we look at all the options, whether it needs to be treated, whether it's just medical management, whether it needs to have surgery, or whether we can give endovascular treatment. And then we discuss with the patients to see what is the best option for them, because every treatment has its own benefits, risks and benefits. And of course, as I mentioned earlier, some patients have surveillance with even after endovascular treatment, there's lifelong surveillance, which you need to have either with a CT scan or an MRI. On the diagram on the right is a picture that's mainly just for example. It's just a small summary of some of our guidelines, which we routinely look at, and they are studied internationally and published internationally, and many such versions of these guidelines that tell us when we need to intervene on patients to make sure that they don't develop complications. Because if you intervene too early, you're doing something you may not necessarily need to do. If you intervene too late, then you're missing an opportunity to prevent complications from happening. And of course, different patients have different risk factors. Some patients have diseases where they show slightly higher risk. So it's not just an absolute size of 5.5. In certain patients where if there's 5.5, but you've got a strong family history, or it's an infectious aneurysm, or it is chest pain, or if the aneurysm is growing much faster than normal, then these patients may need to be treated earlier. Now, as an example of the options, if we mention the total arch replacement is on the left, that's what we talk about surgery. Hybrid means in certain patients where you need to put a stent, or well, you want to put a stent, but the anatomy of the disease requires that some surgical elements need to be done. For example, a bypass from a right common carotid to the left common carotid, or from the left common carotid to the left subclavian. These can also be done. So in these situations, we are combining both a small open surgery as well as the stents. And an example on the right is what you look at is when we are talking about endovascular, complete endovascular treatment in patients who are suitable. What you see is the aorta. There's an aneurysm in the descending thoracic aorta. And so that's the enlargement over there. And you can see as the aorta has been opened up, and you can see the stent being placed. The stent excludes the aneurysm, which means the blood flows through the aorta, into the stent, and back into the aorta again. So the part that's aneurysmal and enlarged is no longer pressurized, which means that the risk of rupture and the risk of any other complications is reduced. So this is one of the methods that we treat. So things that we have to look at when we are considering endovascular treatment, age of the patient, because the patients are very young, these stents can still have certain complications. They can move, they can fracture in the middle, they can leak. And so there are some risks that we will discuss, of course, and we consider on whether patients are better for open therapy or better for endovascular therapy. Other issues such as connective tissue disease or inherited diseases, like mentioned earlier, Marfan's and so on. These patients where the risk of endovascular treatment may be fairly higher because in long term, the results may not be as robust as surgical open repair. Other endovascular considerations, if patients are suitable for open repair, which may be better for them, then we would of course offer that. In patients who are not suitable, then we have to discuss what options we have endovascularly and the risks that come associated with them. Anatomically, which means when we look at the aorta, we have to make sure that the stent is able to sit properly. So it must have a proper normal aorta before and after the stent. If the whole aorta is enlarged, then you can't exclude properly, and you'll have a lot of leak. So these are some anatomical considerations. So basically on the size and the shape of the aorta, which as you know is different for everybody, especially when they have different locations of aneurysms and so on. Other important issues are the branches of the aorta which is affected. As you can see in the picture here, for example, a aneurysm can affect some certain branches which go to the brain, go to the hand and so on, as well as to the kidneys and so on below. So these are things that we consider. Also, we have to look at the cost. These devices are expensive, and look at time. If you want to make a custom device for certain patients, it can take up to 5 to 6 weeks, but it means that the patient must be able to wait because some situations can be more emergent and something may needed to be done earlier. How is it performed? We do these procedures in a hybrid operating theater, which means it's a normal operating theater, but there's also an X-ray machine in the theater. So we do both. We can look at the X-ray while we're deploying the stents. It's performed normally under general anesthesia, so you're completely asleep. We may put a small drain into the spine from the back sometimes, just to reduce some of the risks and complications that can happen. We say access, we mean where do we insert the stents from? As you know, this is a form of endovascular, so it's non-surgical. We don't normally have to cut down. We normally try and insert from either the arteries in your leg or in the hand, or sometimes even in the neck. We do insert these stents under guidance of the X-rays. We have to use contrast in these situations, which allows to see where the blood is flowing and to make sure we deploy it properly and accurately. And then at the end of it, once everything is deployed, we also have to use the contrast to check there's no leakage and that is a good result. And at the end, after that, we have to close the access site. So close the sites from which we've inserted the stent. So in summary, TIVA is what we call thoracic endovascular aortic repair. It's an alternative to open surgery in patients who are suitable. It expands the range of management options because previously you could only offer open surgery, but now we have all options to discuss, and we can talk about the pros and cons for each. We're able to treat patients who are deemed unsuitable for open surgery as well. We've reduced postoperative mortality, which means that there are better results. Sometimes there are lower chances of death and so on, and other complications. But of course, all this needs to be discussed, and we'll weigh the risks and benefits and so on.